Well, welcome, guys. Congratulations on matching. For those who don't know me yet, my name is Isa. I'm one of the second years. And first of all, I want to say thanks to the chiefs. They suggested to do like a series of lectures for you guys. Hopefully, it's going to help you a little bit. Feel free to interrupt me and ask me any questions. And if any senior wanna go and add anything that I missed, feel free as well. So the point of this lecture is just like to give you an idea of what's going on in the hospital, especially on the firm. I know many of us our IMG is coming from a different system, a different culture. So when you come in, we remember like 1 year ago when we came in, everything was new. The system was new. So let's see. So the point of this lecture is just like to step back and look at the hospital, what is going on. There are like too many different things that are going on that we're not used to, especially for those people who are IMGs. Which is how the US health system works. So basically, I mean, the system is working, it's a vicious cycle, and you're thrown up as a new resident into this system, and you have to figure out things, you have to adapt to new things. It's not only about internal medicine, it's about the hospital life. So for example, you're new to Epic, you're new to the things called billing and ICD-10, you're new about the system, how the inpatient and the outpatient system works here. So that's what this lecture is about. So first of all, before I go in, I know we study internal medicine, but I wanna emphasize that what you guys have 6 firms, 1 night float, 2 ICUs, and only 4 electives. So basically most of your first year will be in an inpatient setting. What we are actually doing is, rather than only internal medicine, it's hospital medicine. So if you can just imagine, the internal medicine part is what you study during med school or those stuff, and the hospital medicine is a bigger part, which includes things that we're not used to as IMGs. So my point of this lecture is just to give you a basic idea of what is this blue part that is not covered by the internal medicine that we study in books. So also in the ICU, you're gonna practice critical care medicine, and when you're on clinic, you're gonna get exposed to what is ambulatory or primary care medicine. So let's go on and talk about what is going on in the hospital. You're thrown out on the first day of residency, everyone is working, attending, seniors, and you don't know nothing. So many of these slides are basically questions that I had in my mind when I first started residency. I think that many residents will have these questions, and hopefully there will be some answers that you guys can build up on. It can save you some time. That's the whole point of what I'm trying to say. So initially, in hospital medicine, why do we admit patients to the hospital? As you saw earlier in what Maham was presenting as the HPI, there were many patients will come with comorbidities that are patients is coming with, for example, hypertension, hyperlipidemia, diabetes, coronary disease, and is now presenting with a COPD exacerbation. What you really need to know is you don't need to fix everything during the hospital admission. You need to concentrate on the acute things, and whenever these are stabilized, you can send them out of the hospital and say that this patient is stable enough to get out of the hospital. They can deal with other problems in an outpatient settings. This is just an answer to one question: why the attending is saying, let's now discharge this patient. On what basis are they deciding to discharge the patient? So as long as the patient is, the acute issue is dealt with, and now they're stabilized enough, they can resume care with outpatient settings in a clinic setting. You will face patients and you will hear every now and then patient is in inpatient, patient is in observation. So basically, they're like when patients are admitted to the hospital, they are basically admitted as an inpatient or observation. So what's the difference between those two? Inpatient basically means that the patient is meets an inpatient criteria. They're expecting the patient to be here to be in the hospital more than 2 days, and he needs a lot of care. So basically, like pneumonia, sepsis, septic shock, those people are like require IV antibiotics, and they're probably gonna stay in the hospital for more than 2 days. I try to add like screenshots from Epic so that you become familiar a little bit with what the order looks like. So for example, this is admit to inpatient. On the other hand, for observation, we used to get many observations last year. However, the system somehow changed, and now most of the observations go to the private hospitalist group. But sometimes if the patient has a PCP that is a firm resident, they come to us as well. Basically, these patients, just as an example, like a cardiac chest pain patient who like you ruled out STEMI or NSTEMI, you're admitting him just for a stress test. You want to make sure that his stress test is negative and probably he's going to be discharged within the next 48 hours. Those people do not meet the inpatient criteria. However, they are usually admitted to the observation unit, which is, by the way, the 8 South is the unit mainly for the observation. So as you can see here, place and observation is the order as well. So floors, as Maham talked earlier about it, we usually have 3 basic floors in the hospital that you need to have an idea of what are they. The regular floor is called med-surg, and this is going to help you when you admit the patients, start admitting the patients. The other unit is the step down or the intermediate, and the most critical unit is the ICU. So basically what is different is the level of the nursing care. Usually when a patient is really sick but does not meet like an ICU admission criteria, he can be put in a step down unit where like a nurse is more closely monitoring him rather than just the regular floor. Just for you guys, the step down units are in our hospital are mainly the 4 South, 4 Foster, and CVSU, and 7 Foster. You will notice when you start film that for the 4th floor is usually the cardiac floor, and the 7 Foster usually has the respiratory step down unit. ICU, it's 3 West and 10 West. It's in the tower, which you're gonna like rotate on both of those floors. Many of you who are already...
I'm quick, yeah, if you could go back.
Anyone speaking, Maham?
Yeah, it's me. Sorry, it's me.
Yeah. Oh,
it's me. Okay. Hey, yeah, just the previous slide, yeah. So just the one thing I wanted to emphasize for the interns here too, please put it in your mind, try to associate 4 South, 4 Foster, 7 Foster as step downs, which means 6 patients. So in the morning, if you get signed out for a patient that's on those floors, try to prioritize them in your rounds. Or if you hear a code blue on that floor or a rapid response, try to respond so quickly because that definitely is already someone who's sick to begin with. Okay? Thanks. Thank you, sir. Did you guys hear me?
Not really, but...
Okay. What I was telling the residents here as well, the interns, was that try to associate 4 South, 4 Foster, 7 Foster, and then when there's overflow, CVSU becomes a step down with sick patients. So in the morning when you guys get sign out and your patient is on those floors, try to prioritize your rounds to start with them first. Or alternatively, if you hear a rapid response or a code blue called from these floors, those patients were already sick to begin with, so you should try to get to them quick.
Thanks, ma'am.
Yep, thanks.
So for you guys who are already on floors, you will guys hear something about telemetry. Maybe some of you guys know it, but for those who do not know what is telemetry, basically it's like a technology that we use in the hospital, which allows us to continuously monitor the patient's vital signs, saturations, and the heart rhythm remotely. So as you can see, there is like a telemetry panel order that when you go to the firm, we'll teach you guys how to do it. And what is actually the telemetry? It looks like this. It's a machine with many wires that is connected to the patient. And what they do is there's like those computers with the nurses monitoring like 24 hours what's the heart rhythm, and they're gonna call you and page you if anything looks abnormal. So just so you have an idea what's a telemetry, and if the nurse page you about like a 7-beat run of non-sustained like VTAC or so, just you have an idea what's going on and what is the nurse talking about. When you start admitting patients, you'll find like the admission order set has like fluids, and you'll find like many patients on fluids. Just a note that not all patients need to be on fluids. We usually like start patients on fluids because most patients are coming sick either with like septic shock or like electrolyte abnormalities for which they need some sort of fluids. But just to emphasize the note that not all patients will need fluids, so it's not by default any patients coming into the hospital you need to start them on fluids. Especially if a patient like is in a CHF exacerbation or so, you want to be more cautious with that. Diet, this will be like an important thing in the hospital, and you're gonna see many different types of diets, starting with nothing, NPO, and going forward. I have the screenshot for most types of diet. So basically, NPO is a diet that you will encounter. NPO, sometimes we can give accept steps with meds or ice chips for people who are gonna go to surgery next day. Clear liquids, sometimes we start for patients like with acute pancreatitis who are still able like to tolerate diet, but not a full diet. We advance it sometimes to full liquids. And sometimes dysphagia diet, you will hear about this. This is basically for patients who are having some sort of a swallowing difficulty. Usually the speech therapy will help you with that, to choose what type of diet you wanna choose for the patient. So for example, this is like a dysphagia for level 2 liquids. These are like the SLP will help you with that. Solid diet, it's basically you can choose for whatever like the patient is coming with comorbidities. For example, like a diabetic patient, you want to make sure he has a diabetic diet. Patients with end-stage renal disease or chronic kidney disease, you want to do a renal diet. Cardiac diet for patients with any like cardiac comorbidities. And for someone who doesn't need any restrictions, you can just go on and do a house diet. Some people you will encounter people with tube feedings, people who are coming with like TPN or so, or an NG tube. Usually these types of feeding, the dietitian helps us with that, and we're gonna talk more about the concepts. So what about like people at risk of aspiration? I mean, we learn about this in the med school and the boards, but usually what is really done in the hospital for any patient who's, for example, coming with a stroke, he's gonna have like difficulty swallowing. So you can start, these are 3 separate orders, but this is what is usually done in the hospital. So if you hear like you're attending saying, let's do a swallowing test for the patient, basically it means we start with a swallow study screen, which can be done by the bedside nurse. If the patient fails that, then we go to the next step, which is basically a whole specific team, which is the SLP team that can come and do a dysphagia eval for the team, for the patient, and see if the patient, like what type of diet the patient should have. Also, sometimes they would recommend doing something called video fluoroscopic swallow study, where they go inside and see if the patient is like aspirating or not. So more about the diet. So you'll find people, patients on NG tube, other people, other patients on TPN or PPN, others with PEG tube. So what is going on with these patients? Usually, if a patient is coming with various diseases and is not eating well, eating is a major part that you're going to concentrate on during the hospital stay, because you need some nutrition for the patient to recover well. So there is a temporary thing that we can do for patients while they are in the hospital, which is the NG tube. Another term you will hear commonly is the Dobhoff tube. Dobhoff tube is basically an NG tube, but it's a little bit smaller and more flexible, and it's more comfortable for the patients. So usually we use those Dobhoff tubes initially. For patients who are like still having a problem with swallowing and they still need the NG tube, and you are still like thinking about, some patients are pulling it out of the way and some are confused, you can't keep the NG tube in. Another option that you can do is a TPN or PPN, and usually the dietitian helps with this as well. For example, let's say like a stroke patient, he has this residual deficit in dysphagia. He can't swallow for the long run, but he doesn't need to be in the hospital anymore. At that point, we can think of a PEG tube, inserting a PEG tube, because the NG tube is only a temporary thing that is done in the hospital only. So most, or let me say all, approximately all of the patients you will hear on the floor and in the ICU are sick. They're going to be in bed for many days. And so DVT prophylaxis is a major part of hospital medicine that you need to think about for every patient coming into the hospital. Whenever you want to start a patient on any type of DVT prophylaxis, you want to make sure that you ask yourself some questions, including that, is there any like history of bleeding, or is the patient currently or actively bleeding anywhere? What is the hemoglobin and what is the platelet count? What does the patient's kidney function look like? What's the creatinine clearance? Is the patient on dialysis? And is the patient already anticoagulated? Why to ask these questions? Let's see why. So basically in the hospital, especially in our hospital and most of other hospitals, the most common ways to prophylactically anticoagulate a patient is, you will hear Lovenox all the time. Basically, this is a low molecular weight heparin. It's, I would say, the go-to drug initially for most of the patient, just because it's convenient for us and for the patients. It's longer acting. It's just given a once-time daily sub-Q injection. And it depends on the BMI of the patient. The dose, I'm going to show you the EPIC screenshot in the next slide. The other option you have in your pocket is the heparin sub-Q. So if the Lovenox is the go-to drug, when do we use the heparin sub-Q injections, which is the unfractionated heparin? Usually we do not like to use it, and the patients do not like it a lot because it's a TID injection. So basically you're injecting the patient 3 times a day. But for the patients who are end-stage renal disease or have like a chronic kidney disease with high stages, usually you think of giving them heparin instead of the Lovenox. The problem with the heparin, on top of that it's given 3 times daily, is it has a high risk of HIT, which is heparin-induced thrombocytopenia, compared to Lovenox. So you need to keep an eye on the platelets. And that's why we ask ourselves, like, what's the platelets before deciding on anticoagulation. So let's say a patient is coming with active bleeding, and now you're like stuck. The patient is bleeding now, but at the same time you wanna, he's gonna be in bed for a couple of days, and you wanna prevent developing a DVT or a PE. One option in your pocket is an SCD, which is a sequential compression device. This is a picture of how the device looks like. It's basically a device that keeps compressing on the patient legs to keep the blood pumping in the legs. And one note that you need to worry about is, like, whenever you order this, when you round on the patient, just make sure to see those on the patient leg, because many times you order it, but it ends up like not being like on the patient's legs. So many other patients The fourth option that you have is patients who are already having history of AFib. Let's say their CHA2DS2-VAS score is 5 or more. They're already anticoagulated, and they're coming already on warfarin or some of the common new oral anticoagulants you will hear about is the Eliquis or Xarelto. So in these cases, if there is no contraindication to resume the Eliquis or the Xarelto or the warfarin, you just resume the same dose, and you do not need to worry about like starting Lovenox on them. This is This is the screenshot from what does the Lovenox doses looks like. You just click on one of them. It basically is different doses depending on the BMI of the patient. So as much as the patient becomes more obese, the dose of the prophylactic becomes more. And as you can see, you can still give Lovenox for patients whose creatinine clearance below than 30. And you give heparin usually for end-stage renal disease. Probably you heard already about Medrec for those people who are already on firm, and for people who are coming into firm, you will hear this a lot. Medrec, what does this mean? It's basically medication reconciliation. It's like a process of identifying what's the most accurate and up-to-date list of medications that the patient was taking before coming into the hospital. So usually when any patient coming into the hospital, we ask the nurse to verify the medication from the patient's pharmacy or from the patient, like from the facility that the patient is coming from. And our job as residents is whenever a patient is coming, you need to look at all the medications and verify them. You either hold or continue some of the medications, but you need to have a look as soon as the patient is admitted. Because for example, some patients are like have a history of epilepsy, they are on seizure medications that is preventing them from getting a seizure. So you don't want to like hold the medications or not pay attention to that, and he's gonna end up in a seizure in the hospital.
Isa, if I could just add something real quick here.
Yeah, sure, go on.
So especially for the residents who are doing admissions, the seniors, when you're doing admissions, you don't always have the time to sit there or stand there and then put in all the home medications. And technically the nurses are supposed to help with that, and it's their responsibility to update the MedRec list. So you can always put in a nursing communication documenting that please update the PTA prior to arrival meds list. It's always good to verify with the pharmacy the way Nadine does, which is if you have the time to call and find out what the patient was actually taking, what they filled out. But in the interest of, when you're short on time, you can ask what they're really taking at home and then have the nurses help you with that as well. So try to do that and delegate your work, especially when you're on call.
Thanks, Maham. So other things that you will encounter, which is a part of hospital medicine, is precautions. Different patients are on different types of precautions. So for example, a patient coming with a seizure or like a history of alcohol withdrawal, and you're afraid that he's going to go into seizure, you can put them into seizure precautions. Basically, what does seizure precautions mean is they lower the bed, they put some mattresses around the patient so that in case he falls down, while he's having a seizure or so, it's not gonna he's not gonna get much trauma. Suicide precautions, what does that mean? So if a patient is coming, for example, with suicide thoughts, you're gonna for sure like consult psychiatry, but meanwhile you want to put them on suicide precautions, which means like securing the room, preventing any sharp objects in the room, making sure that the patient has someone to observe them closely. Sometimes, and most of the times, we do a bed sitter, like one-on-one sitter, which is basically some of the staff of the hospital that sits next to the patient and make sure to observe them 24 hours until this order is discontinued. Fall precautions is basically similar to seizure precautions. They just lower the bed and do some precautions like mattresses around the bed. And so they don't allow patients to get up unless like someone is with them. Contact precautions, for example, for like MRSA, C. diff, you're gonna wear gowns, gloves, and hand hygiene. And now with COVID, you're gonna wear N95s and those stuff for the precautions. One other thing that you will encounter is code status. Basically, I mean, people are coming from different cultures. This is not something that every one of us is familiar with. Um, I mean, I come from a culture where by default, like most of the patients are full code and you're gonna try everything for them. Here, the system is a little bit different. On every admission, you need to verify the patient's code status because you will be surprised. Like many patients are gonna tell you, oh, I don't need any like any resuscitation measures if my heart stops or anything, just let me go. So as long as the patient is competent, you need to verify that. I just added an example of like how some of the seniors taught us to tackle this. Whenever you admit a patient and you're taking history, at the end of history, for example, you want to go, let me read it for you. So for example, you want to address it, you would say like, one more thing I want to discuss with you is code status. You want to say that this is something we discuss with every patient who is admitted to the hospital. For example, like for God forbid, if your heart stops pumping, do you wish to try CPR to restore your life? And you want to explain because not every patient knows what does this mean. So for example, this means pushing on the chest with our hands to try to pump the blood through the body, sometimes using electricity to shock the heart if needed, and placing a tube down the airway and attaching you to a ventilator machine temporarily, which is gonna breathe for you. So some people will tell you, yes, I want everything be done. So these people are full code. Some people will tell you, just let me go. So you want to verify and you want to document this as soon as you do this conversation, and you want to change the code status on the patient's profile. Sometimes when patients are coming confused or you don't know what to do, you would just look at the past admissions and you want to have a look at what was the code status at those admissions. Because sometimes a patient wishes to be a DNR and this is documented on the past admission. So you would follow that as well. Maham, do you have any comment? I think.
Yeah, I just wanted to say, so let's just like talking to everybody here, hypothetical situation. Your patient says to you that I want to be intubated, but I don't want chest compressions. How do you respond to that, Vinu?
Sorry,
Did it-
Maham, so you said patient
So
wants
you're talking about code status.
intubation, but no compressions, right?
Yep. So
So
how
we usually try to say that, like doing one thing without the other is basically like not so useful for the patient. Try to explain like the whole procedure, like what is CPR, what is intubation, and then get to a conclusion with that. And if they still cannot, then we can say like put them on full code for now and then like change it later. And sometimes we can also document like they do not want intubation, just compressions, or vice versa. Whatever they say, like just document that as they said.
I think usually like they're a couple. So basically you want to try to discuss with the patient that they need either both or none.
Yeah. Yeah, so the critical care attendings will also try to emphasize this to you in your conversations with patients. Try to help them understand that one will not help without the other. So try to get them to either, because you will see in your experience, if you get to a code where the patient only wanted intubation or only wanted chest compressions, things get really tricky. So another situation is, let's see, so Mahmoud, if the patient comes in and he's in alcohol withdrawal, but he's scoring on CIWA like 6 or 7. So do you talk to him about code status?
You said their CIWA score is 6 or 7?
Yeah, and they came in, your admitting diagnosis is alcohol withdrawal. Do you talk to them about code status?
I always try to talk to them, try to assess their orientation and mentation myself. If he is alert oriented ×3 and able to understand and comprehend, I usually try to talk to them about code status.
Okay. Again, that is kind of a gray area as well. I would err on making them full code. If someone is coming with alcohol withdrawal and possibly they're scoring low still, so that's fine to talk to them, but it's likely that they may have some element of disorientation going on there. So it's always best to use your best judgment. And then when you guys put in your code status, you'll notice that there is an option to click on, use pressors, use, okay for intubation. So try to use as much clarifiers in that order as you can. And that really helps ultimately as well. I can't think of any other situation of people. I don't know. Code status, yeah. And then young people, yes, you will every now and then you'll get a 30-year-old who says, make me a do not resuscitate. How do you guys feel about that? Anyone here in the RCC has thoughts about that? If you have a 30-year-old and you're admitting him for like DKA and he says, make me a do not resuscitate, do you make him a do not resuscitate? Akil? I'll tell you guys what Akil is saying, but he's just answering right now. Or Akil, yeah, Akil can come here and talk. Yeah.
Oh, jeez. Okay, can anybody, I think everybody can hear me. So, I mean, I had a patient like this as well, who was like mid to late 30s. They asked to be do not resuscitate. Seems like, you know, their code status has flipped back and forth in the previous times. It's more of a judgment call. One thing you want to question is when they're coming in this kind of situation and they want to be do not resuscitate. The obvious thing is just ruling out like depression and suicidal ideations, you know, and just making sure they're thinking with a clear head and just asking them like, you know, if they've thought about it, why they want to be this way. Certain people, especially the patient I admitted, he had like a whole host of comorbidities. He didn't seem to be acutely suicidal. I quickly just went through SIGI caps. He didn't meet that. So I just respected his wishes, but it's something to kind of follow up long term. I mean, this was overnight, but this would be something to kind of approach it that way. Yeah.
The way you sort of frame that conversation is you're young, the likelihood of recovery, if I were to do CPR on you, is pretty good. And then, so that's why I, you know, you of course don't want to, you know, impose your choices on that patient, but you can say that, you know, given this, that you're young, you know, the recovery chances are better, consider full code. And then if he still is adamant or she's still adamant, they want to be do not resuscitate, that's fine. But people will frown if you have a younger, relatively younger, without comorbidities, and you make them do not resuscitate. So just be a little bit more careful with those code statuses. Thank you, Isa. Go ahead.
Thanks. So one other thing about the code status is something that you will encounter. You will see some patients' code status stated as comfort care. Basically, this is usually for the critically ill patients whom their prognosis is really poor. And this doesn't happen unless like after discussions with the patient, if he's competent, and the family about like what is the goal of care. So just in case you hear about like what is comfort care, now you have an idea. Basically what comfort care means is stopping all life maintaining interventions, stopping any like ventilations, any medications that would prolong the survival, and rather concentrating on the quality of the life that we are expecting to be like hours to days. Usually we give them medications just to relieve like pain and suffering. You're gonna encounter like most of the medications are given as morphine, Ativan, and those stuff that will calm the patient down, decrease his respirations, and decrease the pain of the patient. So consults, trust me, you're gonna be consulting services on a daily basis. This is one thing that was new to us when we were residents. We don't know how like to tackle any consult. The attending would say like just consult like ID or consult like EP or so. Just so you know, this is like an example of one of the like the commonest services that we usually consult on a daily basis on FERM or an ICU. Cardiology, and this is one thing that you need to know. There are like two groups of cardiology, the main two groups that we deal with. They're like a TCI group and like capital cardiology or like cardiology groups from McLaren. Usually you want to, before you decide to consult, you want to look at the patient's past notes and see which cardiologist is he following. Sometimes like a patient is a TCI patient, and then you like the default is TCI because it's across the road and they're the people who are mainly in the hospital, but you want to verify which cardiologist was seeing. For example, like if a patient was following with McLaren's cardiology group and you ended up consulting TCI, they're gonna be like mad why you consulted us, and they're gonna ask you to consult the other cardiologists. So just so you save some time, and you know that there are like different groups, especially in cardiology, that you want to verify which group the patient is following. EP is another one, ID is another one, GI, nephro, pulmoncrit. Endo, also Endo has like a Spero and the MSU, two services. Usually we do the MSU, but just so you know, neurology, psychiatry, general surgery, cardiothoracic and neurosurgery. So just for example, for people who didn't already start firm, if you wanna like write a page, what usually happens is you wanna consult a service, you would write a page, send the page to the resident who is on call, and this will appear on the web on call. When you are on firm, like you're gonna be taught how to do that. What to send in the page, there are like some important stuff that you need to send. So for example, to go over, this is an example of what you need to include in the page that you send. Bed 722, like bed number 1, you can add the MRN of the patient. For example, if for any reason the patient's bed like changed, you want to mention if this is a new consult or just a follow-up. Sometimes you would just say it's a curbside question and you're not formally consulting them. You would say regarding what problem. So for example, if this is like in a page to ID, you would say regarding bacteremia. Please call, and this would be like, usually this is your Cisco phone number. If this is not your Cisco phone number, one thing that you need to make sure is some services would call you like 30 minutes later or 1 hour later. So you want to make sure that you want to include a number that will be available to you, and you are going to be next to this number for the next half an hour to an hour. So this is one thing that sometimes some residents last year had a problem with. They would like just please call, and they would be sitting in the RCC and then they leave. And after like half an hour or so, the attending or the resident would call and say, you consulted me, and nobody is there. So just make sure you want to thank them, thank you, and you want to include your full name. So for example, like Isa Haddad, and you want to include what service are you on. So for example, firm service or ICU service. I want to touch on some consult teams that are somehow new to us, especially IMGs, and somehow they're like specific consult teams that would do some sort of a job for us. So for example, there is a team called neuropsych. Basically, whenever you have the question, can the patient make his own medical decisions, and you want to answer for that, either a yes or a no, you want to consult neuropsych. You wouldn't consult psychiatry, you wouldn't consult neurology, you would consult this specific service. So if you hear about neuropsych, you now know what is this service for. Podiatry is basically a service that is specifically for the lower limbs, I would say for the foot, ankle, and the lower extremities. So for example, like if patients are coming with like a gangrene in the lower like toes, and they need an amputation, you wouldn't call orthopedics, you would call podiatry for them. Palliative team, what is this team? Basically, this is a team that will help for patients who are complex, who has many comorbidities, and we are thinking that their prognosis is poor. Sometimes consulting them early enough, they can help us with discussions with the family, discussing with them goals of care, wishes, and sometimes they take over and they can discuss with the family and the patient the code status, and they can change the code status, and sometimes they take over and put all the comfort care measures. And it's not only like for patients who are like about to die. You can sometimes, for patients who have many comorbidities, you can think of consulting palliative. They are really helpful in these situations. Another concepts I wanna emphasize is pharmacy. So basically, there are like 3 drugs that we commonly prescribe during like any patient's admission. One of them is vancomycin, the other is warfarin, and the other one is a heparin drip. Usually these drugs, they need monitoring, close monitoring. There are like separate consults, and I added the screenshot of how these orders are put in. Pharmacy can help us with dosing vancomycin. So you would just do the order, and then the pharmacy would care about like following the trough levels, and they're gonna put the loading dose, and when to give the maintenance dose, they're gonna decide it. Pharmacy to dose warfarin. Also, if you put the order, they're gonna follow the INR and give the patients the correct dose of the warfarin depending on the INR. Also, pharmacy to dose heparin drip. This is different than the heparin that we talked about earlier, which is the sub-Q injection. That is for prophylactic anticoagulation. This is a heparin drip for people who are coming, for example, for like anstomy or so. You want to start them on a heparin drip, or like people with AFib. Usually, if you put the order in, the pharmacy will take over and help us with like deciding on the dose of the drip, and depending on the frequent PTT that they will order. So on a daily basis, many patients, this is something new in the US, like not new, but for us, like IMGs, we're not used to it. So you will hear PT, OT all the time. What does this mean? Basically, this is a rehab service that we usually consult for many patients. PT usually it's physical therapy. So basically these concentrate on the function of the patient, regaining function after the medical issues are stabilized. PT sometime like one time somebody told me that PT is lower, like below the waist, and OT is above the waist. But more specifically or more accurately, PT is more concentrating on the movement of the human body. So for example, if you can see the picture here, there is a like this patient probably sitting like 2 days in a row or like 3 days in the bed. They want to come, try to get her up, move her so that to prevent deconditioning. OT is another like team that helps with the activities of daily living. So for example, like they would come, you would see them like working with the patient on like brushing their hair, cooking, and like all those stuff that needs like the micromotor stuff. So we usually consult them, and you want to consult them early enough because these are the ones who are going to help you decide where to discharge the patients. Many patients will need rehab after they come into the hospital. So usually they are like two different orders that you can see. As you can see, this is like an OT order, and this is a PT. We usually put them together, and they're going to write like two separate notes. Each one of them are going to write two separate notes, but usually they are in agreement of what is the plan after the patient is discharged from the hospital. So for example, if you look at this part of the note, it's going to say plan, and the primary DC recommendation is, for example, this patient, they recommended subacute rehab. So some of the recommendations that you will encounter is home with intermittent supervision. This means the patient can go home and somebody to look from the family on him like every once in a while. Home with 24-hour supervision. This patient can go home, but he needs someone to be available with him all the time. Home with home PT or OT basically means they're gonna go home, and some people from the PT team and the OT team are gonna visit him at home and do some exercises. For patients who need more exercises, the next step would be the subacute rehab. And for more aggressive rehab, they will go to inpatient rehab. So if we have a look at it, I would imagine them like as bigger boxes, because each one is like a step up in the amount of the IPR that of the rehab that they're gonna take. So home with home PTOT, then the next step would be more advanced, which is the subacute rehab. These are facilities that are outside the hospital that the patients can be discharged to, and they're gonna get some exercises there before they go home. The inpatient rehab is basically, it is called inpatient. It's inside the hospital. In our hospital, it's the 6th floor in the old building. And for a patient to go there, you need to consult a team, which is the PMR team. It's like a residency in our hospital, the physical medicine and rehab. They basically own the sixth floor and they take care of the patients. They will be the primary care providers for the patient. And if you hear something called the Mary Free bed, it's basically the same meaning. It is the sixth floor. So in case just you hear about it. If you hear about LTAC, which is long-term acute care, this is another term to basically say this is a chronic hospital. We usually consider this for patients who are, for example, like need a long-term like wound care or are ventilated and they need ventilatory care. And basically we're expecting them to be more than like around a month in the hospital, but they do not like meet the inpatient criteria to be in the hospital itself for case managers. For those of you who are already on firm, I mean, definitely you have already talked to them. For those who are going to firm next block or so, case managers, trust me, they are your best friends. They make your life easier because they are gonna take care of almost everything that is not medical. So for example, they're gonna help with insurance, they're gonna help with DPOA papers. If like PTOT decide to send the patient to SAR, she's gonna, or like he's gonna set up the discharge to the facility, the SAR. If a patient is going like with oxygen at home, they're gonna help you provide the oxygen for them. And if a patient needs to establish care with a PCP as well after he's discharged, they're gonna help you as well with that. Bridge clinic, it's highlighted because this is something, if you hear about, it's basically a new clinic that for patients who do not have PCPs, sometimes it's like a transition of care while the patient gets a PCP. Now they have a clinic that the patient can get to after he's discharged, and then until he sees a PCP or so. One like advice I have for you, do not wait until the last day to talk to the case manager and tell her, hey, my patient is ready for discharge, let's set up things, because they need some time to work, especially if the patient is gonna be discharged to SAR. And for your knowledge, SAR doesn't work like usually on weekends. Things go too much slower. So if you have an idea when the patient is going to be like stable enough for discharge, you want to talk to her, tell her like I'm expecting the discharge of the patient to be within the next 2 days or so. So if you can set up these things, this will help a lot, save time. Hospital transfers. When you start admitting patients, you're going to see like many HNPs are saying patient is coming as a transfer from Ionia, patients coming from Clinton. Basically what this means is these are like different Sparrow hospitals, smaller hospitals than our hospital, which is the Sparrow main hospital in Lansing. They're like Sparrow in Carson City, Sparrow in Eaton, Sparrow in Ionia, in Clinton, and in St. Lawrence. And there is like a healthcare facility in Owasso, which we usually get transfers from those hospitals. If we want to transfer patients from our hospital to another hospital for like some sort of a higher level of care or so, the three most common you will encounter is University of Michigan. You will hear a lot about M-Line. This basically means just the phone number of the University of Michigan. You're going to call the operator and ask her to connect me to the M-Line or University of Michigan. Henry Ford is one other common hospital that we transfer patients to. And Spectrum Health, I've transferred some patients to Spectrum, so this is one more common. I don't know, Mahavi, if you have like a comment or so.
Yeah, I just wanted to add something real quick. For the second years who will be doing admissions, if you get a call for a transfer from Sparrow, Carson, Eaton, Ionia, Clinton, any of these sister facilities, or even Owasso, just an FYI, in the interest of time, you can start your HNPs and you can even pen your orders beforehand. If you guys have questions about that, Abdullah, one of the third years, can definitely show you, so just let us know about that so that you can do that to save time. And then Owasso will always come with a paper chart.
That's right. I doubt it's a Sparrow hospital, honestly.
Sorry, what are you saying, Tyler?
I doubt it's a Sparrow hospital. You told me like it's a
No, it's not a Sparrow hospital. Yeah, it's not affiliated with Sparrow, so it'll always be a paper chart that you have to go through. But you can still start an HNP and pen orders for those patients as well.
Yep. And I guess that the attending needs to be on the phone for any transfer.
Yes, absolutely. And that reminds me, attending needs to be on the phone Another unique situation, if ever a patient comes in from one of these hospitals to a hospitalist service first, and then the hospitalist wants to transfer the patient to you, the attending still needs to be on call for that as well. So we don't accept any transfers like that within the hospital if they've come from another sister facility unless attending's on.
Isa, I also have something for that one.
Yeah.
So for the second years taking patients from the ED, if you have a patient whose primary issue has mainly been treated at one of the outside hospitals, Henry Ford Spectrum, U of M, and it's the same problem or it's something that we don't offer, you could talk to the ED attending and tell them that you want to do an ED to outside hospital admission, and then you wouldn't do the admission and they would have to handle it.
Yep.
Okay.
Yep. Very pertinent.
Sounds good.
Isa, we have 2 questions from Enwa here.
Sure.
Do you want to come here, Enwa, just so that everybody can hear you?
So I have 2 questions about transferring the previous one. So I got a patient transfer from maybe from Owa. So we have a physical charge from that. Who we should call for submit or like upload all of
That's
physical charge. Yeah, medical right. Yeah, I don't know who I should call.
I didn't get the one right. I don't know. I can't hear you guys.
Can you guys repeat the question, please?
You guys not hear us? Hello?
Yes, now yes.
I heard it, but it was very low.
Okay.
Maham, I'm hearing you fine, but I know it was kind of low.
So the hard chart that the patient comes in with from OASO, and Noah was asking, what do we do to help get that uploaded into the system? So that's medical records responsibility. The hard chart stays in the hard chart of the patient. And then when the patient essentially is discharged, all of that paperwork goes to medical records, and that's when they're uploaded.
Right.
Any imaging that comes in, you'll see it shows up as PAC-ZZ. That's put in almost immediately into the hard chart. Yeah.
Okay,
So
okay.
it's not your personal responsibility, but yeah.
If I have a patient transferring, like somebody admitted yesterday and I got this patient the following day. So if I cannot see the physical chart, but I want to review it before I see the patient.
Yes.
How can I do that? I want to go to the media to check all of the previous medical treatments.
So there's a little bit of a caveat with that.
Yeah.
What Maham said is exactly correct, but sometimes if a patient is admitted in the evening or at night, they just take the discs straight up to the floor, and sometimes you might need to access those discs. So you have to take the initiative to take the discs down to radiology yourself, especially if it's at night. In many instances, you're supposed to go through the proper channels. But if it comes in the night and you need to see those discs, if someone has a dissection or has a PE and you want to go over
Yeah, right, exactly. So who I should call or where I should go.
The discs are usually in the envelope with the nurse. Sometimes you need to take those discs downstairs and hand it to the radiologist. The techs are on the way to the ED. There's a room where the techs hang out and you hand it to them. Sometimes that's necessary because it doesn't always go according to plan, especially if you need to see the imaging for an urgent purpose. You go upstairs, go pick in the envelope, take the discs out and take them down yourself so they can be uploaded. And sometimes the attendings, the IM attendings want to see them at night, like Dr. Khan or Dr. Olomu. I want to see them at night. You don't want to wait until somebody takes it down because sometimes it might not happen until the next morning. So that's
exactly. Yeah, right. So I want to see the imaging, and also my attending might want to see the imaging as well at home.
Exactly. So you have to just find the envelope, and it's usually in there if it hasn't been handed to the radiologist.
Okay. Another question is, if a patient is not here yet, can we start the HMP? Even though we don't have the, I'm not sure if we can start it.
Yeah, I guess just make sure like go to patient station and like enter the admission, like the new admission, which is under our attending's name. So if a patient is transferring from another hospital, you need to go to patient station and then make sure that you're in the right encounter, which is like under our attending's name. If you go there, you can start a note and all the orders as well.
And what you'll see in was that those patients who are coming in, the encounter will say pending pre-admit.
Mhm.
So you
So we can
you
start
just
on
start
the-
you open that encounter, and then you can go and start a note and pend it, and then orders and pend them. And then when patient comes here, you just edit and sign. Yep. Yeah. Thanks, Isa.
Yeah, am I out of time? I don't know when.
Yeah, Michelle and Randy are actually here. How many more slides do we have?
Maybe, I don't know. I mean, maybe, well, let me see. It's like 29.
I think you're close to the end.
Yeah, I guess I'm just like left with, I'm here. So basically, oh, I'm like 37, 10
Yeah.
more.
So do you want to just talk about, let's talk about the IV access,
Yeah,
and then the
fine.
assessment and billing slide, and then we can talk about these maybe some other day when you have some time. We can give you a few minutes to talk about the rest of the stuff.
Okay, sure.
Yeah.
So just like some common IV accesses that you will encounter is like the regular peripheral IV. You will hear a lot about midline and PICC line and port. Basically, they're like midline is like a peripheral catheter, which does not really reach the heart. It's a midway. It's shorter periods of time. The PICC line is usually for longer periods of time for people who are gonna be discharged on IV antibiotics for 2 weeks or so. It reaches all the way to the right atrium. And for people who are already on port, they are usually like chemo patients already receiving chemo. Let's see, CWA is a protocol. If you hear the word CWA, it's going to be like just a protocol that for people who are on alcohol abuse, and you're expecting that they're going to withdraw within the next 48 hours or so. We can skip that. For the assessment and plan, this is something new, which is like the ICD-10. It's like a system over the states where it's basically used for billing purposes. Ham touched on that earlier about like how to write it. Basically, some terms that you are commonly gonna see. I just wanna like simplify things, specifically, especially when you're starting firm. So basically for patients who are like coming with an infection or like meeting 2 out of 4 of the Sears criteria, we can call it like sepsis or so. Sometimes infection with a source, like a bladder or so, you would say sepsis secondary to UTI. Some ICD, like some people say ICD does not recognize like terms like urosepsis or so. So whenever you go home or so, you can read about the ICD-10 and how they build things and how you need to write them. Simply speaking, if a patient is coming with a creatinine, you need to verify what's the patient's baseline. If it's above the baseline 0.3 or so, you would call it an AKI. Sometimes an AKI on top of a chronic disease. Whenever a patient has low, you will hear like some terms about like acute hypoxic respiratory failure and acute on chronic hypoxic respiratory failure. Simply speaking, if a patient is coming with a low O2 sat or is requiring oxygen, this means you will see or you will write acute hypoxic respiratory failure. If he is a COPD patient, for example, and he's already on like 3 liters of oxygen, now coming requiring like 6 liters or a BiPAP, this would be considered as an acute on chronic hypoxic respiratory failure. For hypercapnic respiratory failure, usually you need an ABG to document that. Basically, you need like a high PCO2, usually if it's like 10 units above the normal. We usually say it's like chronic if it's chronically elevated. If it is worsening than the patient's baseline, we usually call it acute on chronic hypercapnic respiratory failure. If a patient is coming with a CHF exacerbation, usually you need to specify what type of heart failure they have. So you would say like acute on chronic, like decompensated. If it's a HFrEF, which is a reduced ejection fraction, or another term you can use is systolic. On other people are HFpEF, which is a diastolic heart failure. And you would like to mention what's the ejection fraction, especially if it's like a systolic heart failure. People who are coming altered or confused, you will see in the assessment plan, it's documented as altered mental status or acute metabolic or toxic encephalopathy. And when you write the progress notes, when a patient is getting better for like a specific problem, you would say like resolving. If it's completely resolved, you would say resolved. And if it's worsening, you would say worsening. I think that's enough for now.